should be left in.
Thank you very much for the organizers. Thank you, dear Chairman. It's an honor for me to speak here about a complicated issue. It's the issue of synchronous metastasis and if we shall leave the rectum in situ or if we shall take it out. As it is a complicated issue, I want to make it as simple as possible, which means I just will show you some of the literature, show you 2 ongoing studies, and then draw the conclusion. And the conclusion clearly will be that we need more data to draw definitive conclusions. Just to make you aware of the amount of the problem that we have, I'm taking a country like Germany with 80 million inhabitants and with around 80,000 patients with newly diagnosed colorectal cancer per year. Within this group, we have approximately 12,000 patients per year diagnosed with synchronous metastasis, and approximately 4% are in need of immediate surgical resection of the primary due to symptoms, complications, things like ileus or perforation. So I will not talk about the last group, these 4%. I will talk about the rest, and it's still 12,000 patients per year in Germany with colorectal cancer. So this is colon and rectum together. Of course, the group of rectal cancer is a bit smaller. So what's the experience from the literature? And actually, it should be Theo Rüers, the treasurer of our EORTC group, who should stand here and refer about this subject, because he was one of the authors who published one of the most important papers where it was reviewed how these patients presenting with synchronous metastatic colorectal cancer are managed. And he reviewed with his team 7 studies, 850 patients, and they saw that patients receiving primary chemotherapy had intestinal obstruction in 14% over the due course, 3% experienced complicated bleeding, 0% experienced perforation. This last part astonishes me a little bit because I have seen a little bit more in my personal private series, but these are the numbers as reported in the literature. Now it depends on your personality. If you're a personality that says the half glass is full, or if you're belonging to the personalities that say the half glass is empty. I would say 15 or 14% is already something, but the authors concluded it's not too much. For patients receiving primary surgery, they reported that post-operative morbidity occurred in 19 to 47% of the patients, which seems to be the standard over many centers. This is showing you the plot for intestinal obstruction. You can see that one of the studies published by Tibat and co-authors is the biggest one, and the other smaller studies are grouped around, but they came out with 14% intestinal obstruction if the primary cancer, colorectal cancer, colon and cancer, remains in situ. So they reviewed relatively old studies, partly, so we have to ask ourselves what is the situation in times of new drugs that have already been mentioned, especially in times of bevacizumab, an anti-angiogenic drug, which may augment the risk of bleeding, which also may augment the risk of perforation. And this is something our colleagues from the Memorial Sloan Kettering looked at. In this paper, they reviewed 233 patients with synchronous metastatic colorectal cancer. 89% of them never had a primary tumor complication. These are all patients who started with primary chemotherapy. 89% of them never had a primary tumor complication, so just 11% were in need of secondary resection due to perforations or things like that. 7% required emergency surgery due to obstruction or perforation. 4% required stenting or radiation. 20% underwent elective secondary primary resection in the context of metastases resection. And the location of the primary tumor in the rectum was not associated with an increased intervention rate. I think this is an important issue here, that they looked at this specifically because this is the topic of my talk and the reason why you are here. So it does not look like it makes everything more complicated if the primary tumor is located in the rectum. So this is the finding from modern times when bevacizumab is part of the treatment. Here they looked at factors with a potential influence on primary-related complication, and they saw that none of the factors that is listed here had a major influence on complications from the primary tumor. Not the age, not if the tumor was located in the rectum, this is something I told you already, and also not if the patients were treated with bevacizumab or not. There are also some laboratory parameters which all reflect the magnitude of disease. They also came to the conclusion that the extent of disease, the magnitude of tumor load, also has no influence on primary-related complications. Now let me switch to another question, which is the prognostic impact of primary tumor resection. And this is also a complicated issue because in colorectal cancer, we do not have data yet from prospective randomized controlled trials. The only disease where we have these data is in renal cancer, in the times when the kinase inhibitor were not yet available, when we treated renal cell cancer with interferon alpha. This is one of the two studies that have been published in 2001. It was done by an ERTC group, and it clearly could show that the removal of the primary tumor located in the kidney did improve survival when it was added with interferon therapy. But this is another subject. This is renal cell cancer and not colorectal cancer. What is the evidence that we have in the literature about colorectal cancer? And here I have to show you some data from the US, which the authors published from looking into the SEER database. They published 26,754 patients diagnosed with stage 4 colorectal cancer. 17,658 received a primary tumor resection. This reflects a resection rate of 64%. They reported a better survival in patients who had their primary removed. In colon cancer, this was 11 versus 2 months. In rectum cancer, this was 16 versus 6 months median. The overall survival was 45% versus 12%, which was highly statistically significant. Despite these findings, there seems to be a trend in the medical oncology community and in the surgical community to resect less and less. This graph here shows you a certain decrease in the willingness to resect the primary tumor in those patients who are diagnosed primarily with stage 4 disease. Of course, this all is retrospective data. This is an interesting study, the Cairo study and the Cairo 2 study, which looked at this particular problem in 2 prospective studies that compared 2 different chemotherapy strategies in stage 4 disease. And this group from the Netherlands studied 547 patients with primary tumor resection versus 300 patients with primary chemotherapy who have been treated in the 2 Cairo studies. They reported that primary tumor resection was an independent, positive prognostic marker in their multivariate analysis with a hazard ratio of 0.67 in the Cairo study and 0.65 in the Cairo 2 study. This all seems relatively clear at a first glance. You see here the survival curves significantly better for those patients who received a primary tumor resection. So if I have to evaluate the results of the Cairo studies, I ask the question, does this give us guidance on our routine clinical strategy in rectal cancer occurring with synchronous metastases? And I come to the conclusion, no. Because synchronous versus metachronous time point was definitely not analyzed in this study, and the influence of the location of the tumor was also not analyzed. We don't have separate data here for rectal cancer versus colon cancer. This is the advantage of a French study which has been published in the European Journal of Cancer in 2013, and the senior author again is one of the persons who is sitting here in the audience, Michel Ducreux, the future chair of our group. And the advantage of this study here is that they also looked into a prospective stage 4 chemotherapy trial, but they also report results about location, and they restricted their analysis to those patients who presented with synchronous metastases. Let me show you or summarize you the results. They report about 294 recruited patients. 260, 73%, were included with synchronous metastases. 156 patients, 72%, had initial resection of the primary. The basic characteristics of the resection versus the non-resection patients are balanced. Exception for primary rectal cancer, we have more patients who were not initially resected. So there seems to be a trend that if there is a primary in the rectum, the community tends to leave it in situ more often than in colon cancer. In their multivariate analysis, they showed that primary tumor resection is the strongest prognostic factor, with a PFS hazard ratio of 0.5, which is quite a lot, and an overall survival hazard ratio of 0.6, which also is quite a lot. This is showing you the survival curves for overall survival left side and progression-free survival for resection versus no resection of the primary tumor patients. Here in these two curves, all patients with synchronous metastasis are depicted. In this pair of curves, they excluded the patients with rectal cancer, and they are showing only colon cancer patients. But as you can see, the curves look quite similar. The prognosis is a little bit better for the colon cancer patients, and the separation is not as big, so I would not assume that the result would be different if they had shown the survival curves for rectal cancer patients, but they did not do that because the group is relatively small. So where can we go from here? Can we draw a definitive conclusion? No, we cannot do this yet because we do not have prospective randomized trials. And this is currently tried in the German community and also in the Dutch community. And this is a study which is led by Professor Jürgen Weitz from Dresden, who will speak in the next session. The study is called the Synchronous study, which is a randomized controlled study comparing resection of the primary tumor versus no resection of the primary tumor, just going to systemic chemotherapy in patients with colon cancer and synchronous unresectable metastasis. I have to underline, unfortunately, that this is a study which includes patients with colon cancer only and not with rectal cancer. We decided to do that together after long discussions, so it does not help so much for the question of this talk, but there were good reasons to separate these two groups, but probably it will give us some idea and some answer about the principle per se. I don't want to talk too much about the study details. I just want to refer to the other study, which is the Cairo 4 study, which is performed in the Dutch community, and it has approximately the same design as the Synchronous study, with the exception that here the chemotherapy schedule is a bit more specified and all patients have to receive bevacizumab in their chemotherapy schedule. The last two slides are about a setting which is a little bit different. It's the potentially resectable disease. And here I just want to mention a paper that has been studied quite recently, 2 or 3 weeks ago, in the Annals of Oncology. It's the evaluation of short-course radiotherapy followed by neoadjuvant bevacizumab, capecitabine, and oxaliplatin, and subsequent radical surgical treatment in primary stage 4 rectal cancer. This is showing you the study schedule. It's a phase 2 study, synchronous metastatic rectal cancer irradiated by 5 × 5 gray radiation, followed by a combination chemotherapy, which is a modern combination, and then surgery of the primary tumor and of metastasis, and they reported quite a good outcome. And as you can see here in their survival curves, all this looks pretty good. It's just a phase 2 study, but it maybe goes into the right direction. So let me conclude my talk. In irresectable disease, we have currently no clear standard of care for synchronous stage 4 rectal cancer without severe symptoms. It seems to be relatively safe to leave the rectum in situ, but survival may be better if the rectum is taken out. Prospective randomized studies have to prove this. In potentially resectable disease, I would say that 5 times 5 gray radiation followed by a useful combination chemotherapy followed by resection may be a pragmatic standard. I thank you very much for your kind attention.
Can we invite